our website. So just a reminder for those of you who haven't been to our webinars before, the Tropical Australian Academic Health Centre is a collaboration between 5 HHSs in northern Queensland. So that's the Cairns and Hinterland, Mackay, Northwest Torres and Cape and Townsville. It's the Northern Queensland Primary Health Network that we're actually working with, and the Queensland Aboriginal and Torres Strait Islander Health Council and James Cook University. I'm struggling with Teams today. Our research streams are service delivery to regional, rural and remote Aboriginal and Torres Strait Islander populations, innovative health workforce models and non-communicable diseases with high regional prevalence, and of course infectious diseases given where we live. And if none of you have visited the TARC website, please do so. There's a lot of resources, events, calendar events, resources for research up and available for you all to use free of charge. So please have a look at those. Please, while we're here, all of you have done so, mute your microphones while we're talking. If you have any questions at the time, you can pop them in the chat, but I'm going to leave all the Q&A until after Carissa has finished presenting. Feel free to raise your hand when it's time for the Q&A section, or, you know, if there's a small number of us, as there currently are, you're free to just have a question as you choose. If you're a bit shy, put it in the chat and I can read it out for you, but I don't think you need to do that. That's fine. In the Q&A, though, it would be awesome if we were able to see your faces. If your camera works and you felt comfortable, and if you could put that on, that'd be really great, because it's always nice to see the people who are asking the questions. So without further ado, then, Carissa is the Deputy Director of the Sydney Health Literacy Lab. She is the Health Services Lead of the Menzies Centre for Health Policy and Economics. She's also the Chief Editor of Health Literacy and Communication Open, and she's a behavioural scientist working in the public health at the University of Sydney. I've put all these titles here on purpose because they're quite impressive, but also because, again, this whole idea is that how you can develop a program of research, more ideas, one after the other, building on something small, and create a successful research career for yourselves. She has been scientific advisor to the Heart Foundation on national guidelines and screening programs, and the Department of Health and Aged Care, on health literacy, and the World Health Organization on science translation. So I'm going to stop there. And Carissa, I'm going to stop my sharing, Carissa. And if you wouldn't mind sharing your screen, welcome to TARC webinar. And I'm very pleased that you're able to join us today and let us know all about your program of research.
Thank you, Ray, and thank you everyone for taking time out. I know you're extremely busy people up there. I'll just share my slides.
Good to go. Yep.
Is that looking okay? Yeah. Yep. So yeah, as Ray said, I'm going to present a bit today on how I've sort of, I guess, grown a program of research around heart health techs over the last 10 years or so since my PhD. And as she gave a very nice introduction to it, it did start with a really small qualitative study and just kind of grew over time. So it's been an interesting kind of journey. And also, I guess I just am still working on the same issue that I was working on 10 years ago. And we haven't quite solved the problem, but we've been sort of chipping away at it by working with lots of different stakeholders. So that's what I'll be sort of talking about today. So I'm going to just give a little bit of background on sort of how I came to be where I am. The problem that I've been working on for the last decade or so, the different partners that we've worked with to try to come up with different solutions to that problem, and then a little bit about what we sort of came up with for GPs, patients, and also working with primary health networks. So just briefly, my background's actually in psychology, not health. So I did my honours in cognitive psychology, where I was looking at different cognitive biases. You might have heard of these. I was particularly looking at this anchoring bias, where when you get a range of numbers relating to health, you sometimes just focus on the first number that you're given, and that kind of changes how you perceive all the rest of the information. So I started off very, very specific, but always was interested in health. So after a little bit in research consultancy, I came back to academia in psychology and then moved into public health with a PhD after that. And I've sort of stayed in public health as a behavioural scientist. So I'm still interested in cognitive psychology. So it's sort of about how you understand and communicate numbers, and how you sort of try to overcome these inherent biases that we all have as humans in trying to understand probabilistic information. But over time, I've sort of become sort of higher and higher level with how I think about this. So I use models like this wheel. Don't know if any of you have come across this. It's a behavioural science model that's often used in implementation. And it just helps you think through, if I want to address this very specific thing, such as a cognitive bias in CBD risk, what do I need to do to actually achieve something in real life? So in my case, I've been mostly working with that outer grey circle of the framework in the guidelines category. So working with the Heart Foundation on guidelines around heart health checks. So the problem is that although there's been these guidelines to how you should assess and manage CBD risk in Australia for a very long time. So the first ones came out in 2009. We're still not really doing it very well. So there's a bit of a problem on the side of how the assessments are done and how medication is prescribed, but also on the patient side, we know most people in Australia have low health literacy, and they're not really understanding their risk and knowing what to do about that from the way that we're currently managing this issue. So in 2009, this was the risk calculator that we were supposed to use. It was based on the Framingham model, which was a US 1950s data set, so very old, not really very applicable to the very multicultural society that we have in Australia. I think it was all men in the data set as well, so there was a lot of limitations to it, but it was still better than treating blood pressure and cholesterol as individual risk factors. So the idea of this is you combine those things with other risk factors that we can't modify, such as sex at birth and age, to come up with a more accurate way to assess who is at high risk of a heart attack or stroke in the next 5 years. And the idea of this is that it targets medication like statins and antihypertensives to the people who are most likely to benefit. So if you're low risk, you can take those medications and it will slightly reduce your risk still, but it's not really very likely to prevent a heart attack or stroke unless you're over a certain high risk threshold. So this was the 2009 guideline that was just about assessment. And then it wasn't until 2012 that the management guidelines came out. So although there was a way to assess risk, there wasn't actually very clear guidance on what to do about that until 3 years later. And that's when we had a few additions through things like an automatic high risk factor list. So if you had exceptionally high blood pressure or cholesterol, very poor kidney function, if you were over, I think it was 60 and had diabetes, or if you're Aboriginal and Torres Strait Islander with other risk factors, then you would be automatically assessed to be high risk and you didn't actually need to use the risk calculator. You would just recommend medication straight away. So there were more other sort of guidance on when you do use medication as opposed to a lifestyle approach, or when do you use both. And there was a bit of information in there about how you monitor risk. So my PhD initially was meant to be about monitoring risk, but what we found in our very first study was that the initial risk assessment wasn't being done in the first place. So there was nothing really to research about monitoring risk because we didn't even do the first risk assessment. So that was sort of my first lesson in the reality versus the guidelines. So what I identified during my PhD was that if we were wanting to implement a shared decision-making model where we're taking into account the patient's preferences and values as well as the evidence-based guidelines, we pretty much have barriers in every bit of the model. So this model was developed by a colleague of Ray and mine, Tammy Hoffman, and several others. And we used this as a sort of framework for working out what the problem was. So on the evidence-based medicine side, although we had these guidelines, GPs didn't really have time to read and apply those guidelines in detail, and the integration was really poor. So they had to go and read a 100-page PDF to really actually understand what was supposed to be done. On the patient side, As I mentioned, patients with low health literacy is a big problem in Australia and a lot of countries around the world. And we know that they just need more support. It's not that they can't understand CBD risk or what to do, it's that the environment we're providing doesn't meet their needs. And there are solutions to both of these problems. So one example is patient decision aids. There's now hundreds of trials showing that these very sort of structured patient information tools help both health professionals and patients communicate in a way that facilitates shared decision making. But in Australia, there's no kind of central place where you go for those sort of tools. Often the tools you find online are out of date or they don't match the Australian guidelines. So in our case, when I started this work, there were a lot of risk calculators around the world based on the Framingham model. But in America, it was a 10-year model, whereas in ours, it was the 5-year version. And there were just no decision aids available for a 5-year risk model. So all this meant that we had really poor patient care in this area. So we had data showing only 17% of patients were being assessed according to this new guideline. And of those, only 44% were being managed according to the guidelines. So we had a lot of high-risk people not being identified, and even when they were identified as high risk, they weren't necessarily taking blood pressure and cholesterol medication that was recommended to reduce their risk. So as Ray mentioned, I just started off with a qualitative study talking to GPs, and I had a parallel study talking to their patients. So when we talked to the GPs, there were lots of reasons why they were not using this risk assessment tool in the management guidelines. And again, I sort of started framing that in terms of this implementation science model, which basically says there are 3 key barriers to a health intervention. One is capability. So in this case, GPs and patients both needed more support for risk communication. The second is opportunity. So there was a lack of time for training in these management guidelines, which were very detailed, but they were not integrated with the risk calculator. And there was no sort of organised screening program for heart health checks. So GPs were just expected to fit this risk assessment tool into the consultation when the patient had come in with a sore foot. There was no real way and no proper funding model for GPs to do it in a more organised way. And then the third one was motivation. So there was a perception amongst the GPs that this risk calculator was too simple, and it was also really time consuming to implement. So although they didn't have enough time to fill in the risk factors, but they actually wanted an assessment that took into account more risk factors. So it was quite a tricky combination of things affecting the motivation. So as I mentioned, we sort of looked at these higher level functions for where we could try to help some of these issues. So we focused on the guidelines and education and training for both the patients and the health professionals after this study. But this just started with talking to 20 or so GPs and then talking to some of their patients as well. So I've already explained this a little bit, but essentially what I've tried to do since then is address barriers in each of these kind of categories. So the capability, opportunity, and motivation. The red circle is those sort of intervention functions, so education and training. And then the grey policy category we're working in is guidelines. This is kind of a useful model if you kind of interested in behavioural science approaches. It's a relatively simple way to start. And if you want to get into more detail, there are more detailed frameworks you can go into that talk about each of those COM-B categories in more detail. So I knew, having a background in psychology and not general practice, I also knew that I was just going to need to work with a lot of other people. So I didn't really, although I'd done some interview studies with GPs and I worked with GPs, I didn't really have a very good understanding of the broader context that we were working in when we were trying to implement a risk communication tool to help some of these barriers. So I will talk a little bit about who we worked with and why. So I like this quote, which is from a scientist in climate change who you might remember before the disaster of COVID, we had another disaster of the bushfires in Australia. And this was his response where he said, I suppose I was young enough to believe that doing the science was going to be enough and miraculously people would act on it. That was a naive view. And so he had done some modelling that predicted exactly what had happened that year 4 decades ago, when we could have had heaps of time to actually act on that and prevent it. And it just really stuck with me because it's also kind of what I've come to realise over time as well, that although we were quite lucky to have that first qualitative paper published in MJA, the leading medical journal in Australia, and I haven't been able to do that again with any qualitative studies. So I think that was actually really genuinely lucky. It wasn't enough for it to just be in an academic journal, which is probably no surprise to those of you working on the front line of health services, but to a PhD candidate, it actually was something that took me a bit of time to realise that you had to really work with people to make sure your research would impact. So I've sort of done a bit of training in how you think through impact and research translation. And one of the tools that I found really useful was doing something called a power map. So it's quite simple. You can do it for any situation. It's basically trying to think through who are the stakeholders who have low versus high power for the very specific issue that you're working with. So in my case, it was working with the guidelines. And it was the Australian Chronic Disease Prevention Alliance who were planning to update those guidelines. And it was the Heart Foundation who were responsible for the implementation. So those were my two sort of high power stakeholders who also appeared to be highly supportive of what we wanted to do, which was to support the shared decision-making aspects. And then I put the RACGP, the College of General Practitioners, as high support as well, because we were working with general practitioners. They endorsed the guidelines, but I put them as low power in this context because they were not the ones responsible for updating the guidelines. So I wouldn't usually put RACGP as a low power stakeholder for general practice situations, but in this case, it made sense to focus more on the relationship with the Heart Foundation if we wanted to integrate risk communication and health literacy tools with the clinical tools. And I won't go into the low power and low support stakeholders at this point, but there were sort of other approaches to risk assessment in cardiology that were not necessarily supportive of the way that these guidelines say we should assess risk. So what I started to do was to work more closely with the Heart Foundation, but I also, through them, identified the need to work with a lot of different stakeholders. So this is a little bit of a map of the initial organisations that we started working with. So we had a Centre for Research Excellence that was around working with general practitioners to support shared decision-making and evidence-based medicine. So that was the Ask GP CRE. So that gave us a lot of access to GPs to sort of co-design our approaches with. And we had funding from the Heart Foundation and the RACGP. So they were sort of on board in principle through that. Then the Heart Foundation contacts identified My Health for Life, a Queensland-based diabetes prevention and management program, as a key partner that they were already working with in Queensland that they thought might be worth working with on this project. And that led to working with the 7 Queensland PHNs. So there was already quite a well-established community of practice at that time around the My Health for Life program. And I was really fortunate to, just through my Heart Foundation contacts, start to work with them as well. So that's sort of how I came to focus a bit on Queensland, which is not actually why I know Ray, but I've actually ended up doing quite a lot of work in Queensland just through that connection. We did over time start to work with New South Wales and Victorian PHNs as well, through some funding from the Prevention Centre, but there were plenty of things that went nowhere as well. So I talked to the Therapeutic Guidelines, Digital Health Agency, Health Direct and NPS Medicine Wise at various points, and they were like sort of vaguely interested, but it wasn't really aligned with things that they were doing. So it takes a lot of time to build these partnerships and sort of work out where do your interests align with the interests of other stakeholders. And that takes a lot of time. So these are all the people that I was trying to talk to sort of work out where we would go next with this research. And particularly trying to work across the 7 Queensland PHNs was really challenging. I was holding meetings with 50 people at times, just about our little trial. And of course, it wasn't the first priority for the PHNs most of the time either. So really grateful that they wanted to be involved. And then we had recruited a first general practice for a big Queensland-based trial just as COVID hit. So obviously with COVID, everyone's attention had to go to that, and all of those people kind of moved to other places, and we more or less had to start again once COVID had settled down. So very challenging, but important, particularly for someone who doesn't have a clinical background. So although the COVID situation was really challenging with the PHNs, we did identify like quite tangible research projects that we could work with by talking to all these different stakeholders. So we did some work with funding models around the NBS items that support heart health checks, lots of work with the Heart Foundation and general practice and primary health networks to look at different aspects and different implementation strategies that we could use to sort of integrate communication tools with the clinical guidelines, and then working more directly with the Heart Foundation on consumer-focused tools. So that was vaguely the process that we used to identify which partners to work with, but mostly with the Heart Foundation as well, sort of going into general practice level and primary health network level for different studies, but the Heart Foundation has been kind of the consistent partner across this 10 years or so of work. So how are we going for time? Yeah, we've got time. So I'm going to now go through some of the actual interventions that we developed in partnership with the Heart Foundation and some of those other stakeholders at GP, patient and primary health network level. And then I'll probably pause there for questions, but I'm also happy to demonstrate any of these tools if you're interested in any specific tools. I can give you more information and access to those and show you what they look like if we have time. So going back to the GP level where we started, what we identified through those first interviews was that the interface for the guidelines wasn't working for GPs. So there was a separate website with this risk calculator that they didn't really trust. It didn't link up with the management guidelines. Sometimes the PBS criteria didn't match with it. So even if they were prescribing according to this guideline, the patient might be really out of pocket for the statins that they were prescribing. So there were lots of problems with it. And so we started with developing a new interface for the guidelines, essentially a website, which combined those assessment guidelines in 2009 with the management guidelines in 2012 in a way that would just, with one submission, it would show you all of the guideline relevant information for the patient in front of you. So it was essentially a risk calculator, but it also used best practice risk communication principles from the shared decision-making literature. And then it used a decision aid format. So it was designed as an interactive tool where the GPs could play around with different interventions in front of the patient to show them, look, for your risk of 16%, if we start statins, we can reduce that down to 12%. If we stop smoking, we can reduce it down to 10%. And they can go through the different options with the patient in a way that should, in theory, support shared decision-making. So this website was co-designed with a lot of GPs. We also had patient input on the risk communication side, and we had printable resources that sort of would auto-populate from this risk calculator so that the patient could go away with a summary of their risk and what they had decided to do about it with their GP. But we knew that that probably wasn't going to solve the problem for everybody. So more recently, we've been working again with GPs, but also Aboriginal and Torres Strait Islander health workers and practitioners to come up with different ways to support shared decision-making model for those communities. So this was actually only launched a couple of weeks ago, and it was the result of a couple of years of consultation with different communities and different health professional groups. This uses a New South Wales model of shared decision-making that was developed during COVID, and it's much more holistic than the kind of linear shared decision-making model that I was used to So it was my first Indigenous health project, and I feel like I'm still learning a lot about this space. But we were lucky to work with an existing group of researchers who had already done a lot of thinking about how we needed to change shared decision-making processes when working with Aboriginal and Torres Strait Islander communities to take into account some more holistic aspects. So in this model, you can see at the top, there's decisions and options, and at the bottom, there's a weigh up the odds section. That's all very consistent with the standard shared decision-making model, but there's a lot of other aspects as well, like ways of knowing, being and doing, and thinking about family or friends support, as well as support in the community. So it's a bit of a looking out at a more holistic way of helping people be healthy rather than jumping straight into the numbers and whether they should take a statin. So they are sort of the two main resources we've developed that are aimed at general practice. But then we were also looking at the consumer and patient side of things. So we did a lot of work on this concept of heart age. So the Heart Foundation has a heart age calculator that they use for health promotion and awareness campaigns. And it's very effective for that. Millions of people have used it. But when we've tested it in more detail, we found it doesn't really help people understand what the actual risk is or what they can do about it. So we've sort of tested supplementing that heart age calculator with more shared decision-making friendly risk communication tools. So this is basically the patient version of the GP tool, where it talks through the risk in a bit more detail, and just one at a time. So it's not all kind of squashed together into one web page, which is what the GPs wanted. For the patients, they wanted it more step by step. And they also wanted more practical support for the lifestyle change aspects. So this is an example of an action plan that we tested in a few trials, actually initially in the diabetes context. And we were able to show that people with both low and high health literacy can benefit from these really specific planning tools. So for example, this is one about smoking, but we've also got unhealthy snacks and physical activity versions of that. And it just helps people think through a very specific plan that they can just start acting on straight away after the consultation to change a single habit. So it's not going to do a huge amount for the overall risk, just changing the one habit, but it's something that they can go home and do straight away and then build on that over time. Just staying on that. So with that one, we were able to test with in quite a big trial. So we had over 600 people with varying health literacy levels from low to high. And we were able to show that the format actually without the heart age was the best for helping people with varying health literacy both understand their risk and then feel, I guess, empowered to take some action on their lifestyle. So more recently, because the new guidelines came out last year and they were a little bit different in how they describe the different risk category, we've integrated those patient tools as well as some other skill building tools that were developed in other programs of work into a new website. So that's now what we're focusing on to support the current guidelines. And then going back to the Aboriginal and Torres Strait Islander stream of work, this is an example of a printout for the patients that you can print off the sort of GP-focused conversation guide website. So again, this was co-designed with community members, and it just gives it more of an overview of the risk level, the risk factors, what you're going to focus on right now, as well as some of those cultural aspects that came from the Agency for Clinical Innovations model. So that was all still on capability, so helping people understand the risk guidelines. I'm going to move on now to the opportunity bit of the COM-B model. So this is where we had issues around access and time. So for this program of work, we had some funding from the Prevention Centre to look at the role of primary health networks specifically. So we'd already worked with PHNs a bit in Queensland, as I mentioned, but we wanted to see whether what we'd learnt there actually applied in other parts of Australia. And so we just started with a stakeholder interview study where we were talking to primary health network staff in every state and territory about what programs and activities they were doing that could support heart health checks, and trying to identify ways that we could implement these patient and decision-making tools into things that were already being done. So there were sort of 4 main categories that we sort of thought of as implementation strategies for our tools. So one was internal roles. So particularly in Queensland, it was quite well set up with the GP liaison officer roles. So they already had a community of practice across the 7 PHNs in Queensland, and they were going out and seeing their practices every 6 months. So they were already funded, those roles, and they already had some GP education and quality improvement initiatives that aligned with heart health checks. So we could work with those officers to sort of get our tools out to a lot of different GPs through roles that were already sort of business as usual. So in Queensland, that was sort of our main focus. For GP education, we worked with some bigger sort of education events, GP, like statewide kind of GP conferences that the PHNs in Victoria were putting on. And in New South Wales, we were working with quality improvement programs. So some of you may have heard of or used the PIPQI program, which was like an incentive for GPs to share their data with PHNs. And then there were particular areas that they were generating audit and feedback reports on, and that included CBD risk assessment measures. And then the thing that we focused on the most is the 4th one, clinical software. So we worked with both PHNs and medical software providers to try to get at that opportunity issue where it was taking too long for the GPs to access and use the risk calculator. I think I've got that on the next page. Sorry, there's a few ways we work with software. So one way was the clinical software. Another way was working with the PHN health pathways, which some of you may have accessed. So almost all PHNs have a CBD risk assessment and management pathway, or they have access to another PHN's one. And what we did here was, just as a really low resource implementation PHN in New South Wales, they were already updating their health pathway around CBD risk assessment to add some information about a new MBS item. And so we just gave them a bit of extra information that would give them a link to the decision aid version, so that new interface that we developed. And in November 2019, a newsletter went out, so we got a little jump in use, and it more or less, apart from COVID, just maintained itself over time. So we didn't have to really do anything. We didn't have to pay anything. The PHN had already employed a GP to rewrite the pathway. And that was just a really easy way to show that you can actually implement things into existing software systems that GPs were already accessing. And the unexpected thing with this is that we only put it in one PHN health pathway, but over time it started getting referrals from all these other PHN health pathways. So in the end, I think we had about 16 different health pathways that were consistently referring clinicians to our website interface. And that was with us doing pretty much nothing. So that was a really good example of a good implementation we are hoping to use again with these new guidelines, where we can start small and it just kind of spreads over time. That's a low resource option. The clinical software, to come back to that, sorry, I got the order wrong before, is a little bit of a higher resource option. So it does take a bit of IT development to integrate a risk assessment tool with patient records, but it can be done. So in this case, we had, if you look at the top, there's these little icons. So this is top bar. If you've used Best Practice or Medical Director, you may have seen it. And basically the GP just has to click once. They click that once and anything in the patient record will auto-populate the risk factors in the risk calculator and also auto-populate the communication tool. So it does the risk assessment, the management recommendations, and the decision aid that the patient can walk away with just a single click. So that can be done, but it takes a lot of money to develop and maintain, because you have to then pay for the upkeep of the development. But we are looking into how we can do this with the new guidelines, which are a little bit more complicated than the ones we were working with here. So I'm going to move on now to motivation. So that last bit of the COM-B model. So this is where, like, we knew the GPs, with good reason, were not necessarily liking the risk calculator because they knew that it was a bit outdated, didn't necessarily apply to the Australian population, and they were having trouble with this opportunistic screening model. So trying to fit that assessment into consultations that were really about other things was not really working. So most recently, I've been working with the Heart Foundation on a new sort of model of care for CVD risk screening. So we actually started this in COVID, and I didn't know, we planned it as a small pilot, thinking that during COVID it wasn't going to be a big priority, but we ended up getting 300 general practices interested in it. So it was obviously interest in solving this problem of the screening model. So the first pilot we did with 200 general practices during COVID, and we were able to show a 14-fold increase in MBS billing for heart health checks. So that's like a huge increase, although from a low kind of base rate. And basically what we do is just go to the general practices, help them identify eligible patients in their records, and we just send an SMS to the patients to invite them for a heart health check. It's very simple. The software side of things is not totally simple, but it is actually set up now quite well. So once you have it set up, it's not very hard to enable this in general practice. It does require some management on the staff side of things, because once you send out these SMS, you get inundated with calls to book in the heart health check. So it's taken a little bit of tinkering around with different size practices to work out, like, what is your actual capacity to manage the heart health checks once we send this out. But it works. It was acceptable and feasible to both the general practice staff and the patients once we ironed out some of those logistical issues. And we're now about to report on the second trial. So the first one was meant to be a small pilot, even though it was with 200 practices. And then we set up a proper trial. So we actually had it as a registered trial, and we wanted to target higher risk populations as well. So we had more regional general practices and more lower socioeconomic areas. So we've just done that, and we did something a bit different the second time. So we still sent out an SMS, but then we sent out a second reminder SMS to see if we could increase that 14-fold increase. And it did increase a bit more, up to 16 in this latest trial. So that's not published yet, but we have got the results. So we've sort of been able to show now that it worked in a slightly easier to reach population in the pilot, and then a harder to reach population in the second trial. So as well as that, one of my roles in this program of work, so it was led by the Heart Foundation, but I was really conscious that if we're going to introduce an organised screening program, there's also a risk that we would increase inequities in CVD outcomes if it was just the worried well coming in for the heart health checks, particularly with the cost of living issues and the price of going to a general practice now. So we did a separate trial that was looking at different wording in the SMS. And this was using some ideas from behavioural economics. So sort of going back to my cognitive psychology days a little bit, where we just had quite small changes to the SMS message that you can see in red here. The first one was the one we used in the pilot, where we say your age and other factors may raise your chance of a heart attack or stroke. And then we just reframed that a bit to say that the GP had allocated time for you to attend a short heart health check in the next 2 weeks. So 2 weeks was the time period that the practices were comfortable with. So they could choose when they sent out the SMS to a time where maybe it was a low period, or they knew they would have a lot of staff on. And that was a time that they could kind of plan things. And just that slight change was enough to close this health literacy gap that we knew would be there. So if you have a look at this graph, it'll take a little bit of explaining. The blue line are the people with low health literacy. The red line is people with high health literacy. So if you look at the control dots, the very start of those lines, there's a gap between the blue and the red. So that is almost always the case for any prevention measure, that people with low health literacy are less likely to take up the prevention measure than people with high health literacy, and there's a lot of reasons for that. But just changing that scarcity framing that we've already allocated time for you. You have to come in the next 2 weeks if you want to do it. That was enough to close that gap. Ended up going with that scarcity message. The last message, the regret one, also closed the gap, but not quite as well as the scarcity one. And there was also an issue with the acceptability of that one. So you can probably guess that receiving a message that says, if you got heart disease, would you regret not making an appointment, is a little bit negatively framed in a way that people didn't really like. And the Heart Foundation, as the main stakeholder here, were really sensitive to this at the time because they had had a backlash to a similarly worded campaign that they'd put out. So they weren't even going to consider using this message, but we included it in the experiment just to see if it would have the same effect. So scarcity and regret are both kind of nudges or behavioural nudges that have been shown to work in other screening programs. So they did both work, but we went with the scarcity framing based on the acceptability. So finally, on motivation, to address those GP concerns about using this old risk calculator developed in America in the 1950s, we now have a new algorithm. So it's taken a while to get here. The Heart Foundation has tried to fund Australia-specific algorithms, but we just don't have the data linkage to do it very well here. So what we've ended up using is the New Zealand model called Predict. So it's not exactly the same population as Australia, but it's closer, it's more recent, and it includes new risk factors that weren't in the calculator before that GPs wanted to be accounted for. So things like being on medication for mental health issues, already being on medication for blood pressure or cholesterol, and you still want to be able to assess the risk. And also socioeconomic area, which was already in the American and the UK calculators, but we've never had it here before. So those sort of things were added in. So it is a more complicated risk calculator. There's more factors that you have to put in. And there's also a sort of more complicated step in that you can reclassify the risk. So if it comes up as intermediate or medium risk, that's where you can take into account additional factors such as being from a higher risk ethnicity or having a high coronary artery calcium score if you've got a heart scan result. Those sort of things can sort of reclassify the risk up to high risk. So there's a few new features in it, and those features do, to a large extent, address a lot of the issues that GPs had been raising way back when we did that first qualitative study. So they wanted all the risk factors in there, even though they didn't have time. And so now they're in there. And to address the time issue, it's not yet integrated with clinical practice software, but that's something the Heart Foundation is working on at the moment. And there's different options. So there's sort of like a minimal set of risk factors that you have to put in. And then if you have the time and the data, you can put in those extra factors to sort of fine tune the risk assessment. And as you can see here, it also does incorporate that same interface that we tested extensively with GPs and codesign with them. So the decision aid kind of communication tool is now integrated into the main clinical risk calculation instead of being a separate website. So that's pretty much what we've done for the last 10 years. There's been other little side studies along the way, but they're sort of the ones that I think have worked really well because we have done that partnership with the guideline stakeholders throughout, as well as co-designing with the end users. So working with both the patients, different communities who might have different needs, and the GPs and practice nurses as well, who actually have to implement these interventions. So our next step is to see if we can go even higher level. So we're working with the National Health Literacy Strategy, which is being drafted as an action under the preventive health strategy at the moment. So that should be out for consultation soon. And we're hoping that this strategy will be sort of the first step in having more systematic ways that we can introduce these type of risk communication and health literacy interventions across health areas. So we're not having to redevelop these tools every single time a new guideline comes out. So I'd just like to finish by acknowledging the many investigators involved in these projects, as well as the partnership with the Heart Foundation and our funding from NHMRC, Heart Foundation, RACGP, and the MRFF as well. So thank you very much, and happy to answer any questions with the last 10 minutes.
Well done. Thank you. Thanks very much. I'm going to open it to the floor. Thanks, Carissa. Open it to the floor. Does anybody have any questions for Carissa about developing that program of research? How she went about it? Anything that you have at all? What would you like to ask Carissa about that? I can start because I'm not shy unless anyone. I don't see any hands. All right. Carissa, it struck me that you're a psychologist, right? You're a behavioral scientist. You've moved into a space that many would perceive as being quite medical, right? It's like, but that's actually not really the point. The point is that you pursued theoretical constructs all the way, and that just happened to be the idea that worked at that time. Would that be fair to say for you? Could it have been anything, I suppose, is the question, if other ducks have lined up? Or were you desperately, curiously interested in pursuing what people might consider to be fairly medically oriented?
Yeah, that's an interesting question. Well, I actually started off in cancer research when I moved into public health. So a lot of those same sort of things I was doing in cancer. So looking at shared decision making and creating decision aids for very specific medical decisions around cancer treatment and cancer trials. So I think you can apply a lot of these sort of similar, the psychology behind it, you could apply to sort of any health issue. But I really liked working in heart disease prevention because firstly, it feels like you can do something before people get sick, which I really like. And I have always been interested in doing that on the prevention side rather than the treatment or diagnosis side. But pragmatically, as a researcher, so working in a psychology department where I started, I didn't really like doing these sort of hypothetical student sample research studies, which would sit in a very obscure psychology journal and never have any impact on the real world. So what I love about working in health is that you can still explore these really interesting psychological concepts, like why do people resonate with the concept of heart age? But it feels like it could contribute a small amount to actually leading to better health outcomes in the end.
Jacqueline. Oop, you're on mute, mate. I can see you. Yeah. We're nearly there. Hey.
Thanks for that. I'm a speech pathologist, so I should also say that this is heart health is not my area, but I am very interested in that background about behavioural change. And it's something I try to, I work at JCU, so I lecture some students, and I have a subject where we talk about making the drivers of change and making change. So that was quite typical for me. I was wondering if you could just, if you could put up that slide again about the power support map.
Yeah, sure. Let me just bring it up.
So, is that what it's called? Is that the name? If I Google power support map, is that what
it's called? A power map. And I looked about this in some sort of policy change training, and they called it a power map, but it may have other names as well.
Okay. All right. So I'm just wondering if you just could talk to that a little bit more about how you basically are these partners so these are possible partners. So these are people that you're thinking may help you. And so you basically had this up and you were slotting people into where you thought they fitted. Is that correct? Just trying to understand the process.
Yeah, sure. So yeah, basically we were sort of thinking through, as a research team, we were thinking through who do we need to actually partner with if we want to get these risk communication and decision-making tools to general practice in the next guidelines. So we knew that there was going to be a guideline revision. So that was when we started thinking this through. So already we were working with the Heart Foundation, but it wasn't actually the Heart Foundation who were doing the guideline development. It was the Australian Chronic Disease Prevention Alliance, which is bigger than CBD. So we sort of, over time, with talking to these different groups, sort of thought we had alignment with the Heart Foundation mostly, but also the Stroke Foundation, because they're obviously interested in preventing stroke. So they're sort of aiming towards the same thing, and also diabetes as a key risk factor. There was like some alignment there, and we had already worked with Diabetes Australia as well to develop those lifestyle action plans. So that was originally developed for diabetes management to help people sort of reduce unhealthy snacking and keep their HbA1c under control. So that's why we've sort of got those three groups in the both high power, because they were part of that alliance, who were funded to develop the guidelines, but also high support because we had some alignment with them already. Whereas if you look in...
Sorry, by support, do you mean being able to support your program, or do you mean support from the perspective of the patient, the client?
So support as in our goals were aligned with their goals.
Right.
Yeah. So it wasn't that the Kidney Health Australia group or Cancer Council would be like opposed to what we were doing necessarily, but they weren't actively kind of working in that same space compared to those other ones. And then, yeah, so I guess when you think of support, it's you can think of it as, are our goals aligned?
Yeah. And then, so, you know, given limited resources that we all face with, I'm just wondering, where would you then mainly target your focus? Would it be the high power, high support group? Is that where you would mainly want to target your, you know, in terms of building those relationships?
Yeah, and especially as like an early career researcher, you've got a lot of pressure to sort of get your next contract and get your papers out and things. And so it is a time and capacity issue. So this just really helped me think through, who should I spend time building a relationship with? And so that's why I very much focused on the Heart Foundation. And that's why I focused on Heart Foundation rather than RACGP, even though I was working with a lot of GPs. The RACGP has so many different interests that it made more sense to me to focus on the CBD. And it's literally, just a time issue. And as a non-GP, I think it's a little harder to work with the RACGP for me, whereas another researcher doing the same thing who had a GP background, maybe they would have picked out RACGP as more aligned. And sometimes, just one thing to add on that, so the low power, low support group, sometimes it is worth engaging with them, especially if you think they might be opposed to what you're going to do, or if it's a different health profession where there's a scope issue, where maybe, say, as a speech pathologist, there's something you want to do, but it sort of goes into the same territory as another health profession. You might want to engage with them to make sure that you're not going to step on any toes or raise opposition. And that's often an issue between pharmacists and GPs in my context. So sometimes it is, in this case, I put cardiologists in the low power, low support part because they had different guidelines.
Okay. All right.
Thank you.
Thanks.
I'm going to go to Wendy, and then Jenna has a question in the chat I'll read out. Wendy.
Thank you thank you so much, Lee, and thank you so much, Carissa, for the very informative presentation. I am a psychologist, so I echo your point. We publish paper, then sometimes, except from citation, it seems we don't really make a difference for the world. So that's why I moved to intervention as well. So I'm doing mindfulness intervention for diabetes patients. And I noticed that in your consumer educational, and then the step 4, listen to my favorite music or podcast. So in the future, if you need the podcast, mindfulness podcast, maybe contact me.
Okay.
Okay, so not so much a question, more about a self-promotion, Wendy.
I actually forgot there was a podcast in there, but yeah.
All right, I like your style.
So what is your podcast about?
About mindfulness, for example, different practice technique. For example, body scan, walking meditation, sit, attention focus. So we include different options so that they can choose which one is the best for them.
I'm going to
Yeah,
let you
we
guys
all-
take that offline if that's okay.
Yeah,
It sounds
I
like a
will
really
send you an email,
interesting thing.
Carissa.
Maybe you can
That would be great. Thank you.
send Carissa something on that, because I'm running out of time. We've got 2 minutes left, and Jenna has a question about stakeholders. So for context, Carissa, Jenna has just done her confirmation for her PhD candidature. Her project will involve truckloads of stakeholders. Her question is, how did you approach managing expectations of all the various stakeholders throughout that very long process? Which I think is a really important question.
Well, if I go back to, let me go back to that slide. Yeah, you can't do everything for everyone. So go back to, oh, lost it now. Never mind. Yeah, I guess that's where that power map helped me as well, because basically I decided that I was going to try to align as much as I could with the activities of the Heart Foundation, because that was my best bet for getting my intervention into a clinical guideline where it would actually have large reach. And I don't think I did always a great job of managing all the other stakeholders, particularly when I was trying to work across 7 PHNs. I found that was really difficult, particularly because the staff kept changing. So every time you got a staff change, you had to sort of re-establish the relationship with the PHN again. And sometimes their priorities had changed even before COVID. And that's the whole point of PHNs, is to respond to local needs assessments and do commission research that meets the needs of their local area. So I probably wouldn't do that again, trying to work across a lot of PHNs at once. So what we moved to after that experience was just working with PHNs sort of one at a time, more flexibly. So I would have loved to have done like a really big implementation trial after COVID, but we decided it was probably better to just take a different approach with each state or each PHN, depending on what would actually align with what they were doing. And although scientifically it maybe isn't as interesting a study design, it worked a lot better for actually getting the intervention to more GPs.
Excellent. Thank you. It is 2 o'clock. My job is to make sure that we don't keep you any longer. So thank you once again. Thank you very, very much, Carissa, for sharing that with us. I'm sure anybody, if you'd like to contact Carissa, I'm sure that'll be fine. The webinar is recorded and will be up on the TARC website, as we do all the other webinars, anytime that you'd like to watch it. Thanks again, Carissa. And the next webinar for next month, last Wednesday of the month, will be about different ways of working with consumers and community organisations in your research. So promos for that will be coming out soon, as will registrations. But once again, thanks everybody. Got lots of thank yous and wonderful stuff in the chat there, Carissa. Everyone's looking
Thanks
great.
for your time, everyone. Thank you, Ray.
Thanks, mate. See ya.